So we ended part B of chapter 13 with sight and vision. And then we are going to kind of skip over, I think gustatory, taste, and olfaction was at the end of part D. And I just made the lecture exam and I didn't include any taste or olfaction questions. So you can kind of skip over those two senses. I want you to focus on vision and hearing for the special senses, which we'll start here in part C. Charisse, the lab exam, I think it's only like 25 points. So I would expect 20, I'm probably, how many labs do you guys have? I think 5. So maybe expect 5 questions per lab. That's probably how I'll arrange it. So 25 questions, 25 points. Okay, so the inner ear mechanoreceptors enable hearing and balance, and specifically the organ for hearing is your cochlea, which is that snail shell-shaped organ within the inner ear. Our hearing apparatus allows us to hear an extraordinary range of sound, and that's the cochlea. And then our equilibrium and balance receptors will continually inform the nervous system of movement and position. And those will be your semicircular canals, your vestibule, your saccule, and we'll go through those. So this will be a review from anatomy. We divide your ear into external, middle, and inner ear. And the receptors for hearing and balance will respond to separate stimuli, and they're activated independently. So they're in 2 separate areas of the inner ear. The external ear has the auricle, that's the shell-shaped funnel, that funnels sound waves into the auditory canal. And then your external acoustic meatus is your auditory canal. It's lined with hairs, sebaceous glands, and also earwax glands. And that's just, the earwax serves as a protective mechanism to try to keep anything harmful kind of away from the eardrum, your tympanic membrane, which is a really delicate structure. So removing wax from your ears, I usually tell my anatomy students, isn't necessarily, you kind of want wax in your ears unless it's like super gross, to just kind of protect anything harmful from getting to the tympanic membrane, which is also part of your external ear. It's the eardrum, it's the boundary between the external and middle ear. The tympanic membrane is what will vibrate in response to sound. So sound waves come through the external auditory canal. It will vibrate the tympanic membrane, and those vibrations will transfer the sound energy to your bones of the middle ear, which are your ossicles. So you hear a review from anatomy. We'll focus in on the middle ear now. Here are the 3 bones of the middle ear. They're so tiny. The stapes, malleus, and incus, they'll all fit on the head of a penny. They're so tiny. The middle ear is all filled with air. And here's the pharyngotympanic or auditory tube, which will collapse, as well as the tympanic membrane will also kind of fold out of place when you go up into higher elevation. And the popping back of the tympanic membrane and also the auditory tube back into place, that popping sound is from them trying to equalize pressure. And then the internal ear is where your hearing and equilibrium and balance will occur. So these 2 kind of, they're called labyrinths, will be filled with fluid. The cochlea is responsible for hearing, and the semicircular canals and vestibule up here is responsible for your equilibrium and balance. So the middle ear, it's the tympanic cavity. It's filled with air. It's also filled with those tiny bones. I'm not going to ask you too many anatomy questions about this, but you should know that sound will come through the tympanic membrane, vibrate the tympanic membrane, and those vibrations will be sent through these tiny bones. And through the laws of physics, because the vibrations are so much larger than these teeny tiny bones, those vibrations get amplified, I think 100-fold, as the stapes pounds against what we call the oval window. The oval window is just a membrane that separates out the middle ear from your internal ear. So those vibrations from the stapes kind of pounding against that oval window will send waves through the fluid in the vestibule as well as the cochlea. The middle ear, you have your auditory tube. It's usually flattened, but it can be opened by yawning or swallowing to equalize pressure. So that is your auditory tube. It connects your middle ear to the nasopharynx, so it empties out into your nasal part of your throat. Here are the auditory ossicles, those three small bones. The malleus is the one that's secured to the eardrum. The incus is the one in the middle, and the stapes is the one that kind of touches or fits into that oval window. You also have muscles within the middle ear that will contract in response to loud sounds to prevent the damage to hearing receptors. So you have muscles to try to like control these vibrations of these ossicles for any really loud sounds. If you're at a rock concert, you're hearing a jet plane, even a lawnmower, take good care of your ears. You don't want to be around loud sounds because you will not be able to hear when you get older, like my dad, if you do. Otitis media, or otitis, so this is an inflammation, it's an itis word. This is a middle ear inflammation. It's commonly seen with children with a sore throat. It's also the most common cause of hearing loss in children. An infection can cause your eardrum to bulge outward and become inflamed, but you can give someone antibiotics to help with that. So then the inner ear we refer to as the labyrinth because it's this maze of kind of chambers within it. It's located in your temporal bone right behind your eye socket. The bony labyrinth is the system of channels and cavities that worm through the bone. We divide it into three regions: the vestibule, the semicircular canals, and the cochlea. And these are filled with what we call perilymph fluid, which is similar to cerebral spinal fluid. And the membranous labyrinth are a series of membranous sacs and ducts that are contained within the bony labyrinth. So you kind of have this bony maze and then a membranous maze within that. And it's filled with a different kind of fluid that's potassium rich, and we call that endolymph. So here's a look at the inner ear, the membranous labyrinth of the inner ear. So you can see here the semicircular canals, you have three of them. Here's the vestibule is made up of two different structures, the utricle and the saccule, which are kind of right next to each other. And again, the semicircular canals, the utricle and saccule, they all have different kind of functions or jobs in the equilibrium and balance. But the hearing, the sense of hearing all occurs in the cochlea, and we'll kind of spend most of the time just understanding what the cochlea is. And that's what I kind of want you guys to do too. You have the vestibulocochlear nerve, which is one of your cranial nerves. I think it's cranial nerve number 8. The vestibulocochlear nerve divides into just a vestibule branch and a cochlear branch. So the vestibule branch goes to the vestibule, and the cochlear branch of that cranial nerve goes to the cochlea. And we'll talk about what the spiral organ is, the cochlear duct, and what that refers to. So you can see here where the stapes connects to the oval window. And when the stapes kind of pounds or vibrates against the oval window, that will send out waves through these fluid-filled chambers. And those waves will cause hair cells to bend, whether you're in the vestibule, the semicircular canals, or the cochlea. And the bending of those hair cells, the bending will produce depolarizations in these nerves. And that is what the energy signal that these nerves pick up and gets sent to the brain. So that's the SparkNotes version. Stay tuned for more detail. So here we have our inner ear, the vestibule. It's the central egg-shaped cavity. It's made up of the saccule and the utricle. They have different receptor regions that respond to gravity and changes in position of the head, whether you're looking down or side to side. So when you go on some of those spinny rides at the state fair, which I strongly dislike, you feel since your head is spinning so much, you're messing with the equilibrium and balance in the vestibule. The semicircular canals are 3 canals oriented in 3 planes of space. The ampulla is an enlarged area of ducts of each canal that houses equilibrium receptors that will respond to rotational movements of the head. So the vestibule will respond to more changes in position due to gravity, and the semicircular canal will respond to angular or rotational movements. Other than that, I don't want you guys to know too much about semicircular canals or vestibule. What they'll do is any sort of change in gravity or the change in head position or rotational movement, that will just cause different hair cells to bend in your semicircular canals and vestibule. And the bending of those hair cells depolarizes these nerves of the vestibular branch. The cochlea then is more where the sense of hearing occurs. It's a small spiral conical bony chamber. It's the size of a split pea. So keep that in mind. And from this picture, the cochlea looks, oh, you probably think it's like the size of a snail shell, but it's the size of a split pea, or so a small structure. It contains the cochlear duct, which houses the spiral organ, also known as the organ of Corti. The cochlea is divided into different cavities, into different chambers: the scala vestibule, the scala media, or the cochlear duct, and the scala tympani. And I'll kind of show you here. So how we look at the cochlea, this is probably a better picture, but so what it's showing you, if you look at this, like the cochlea is rolled up like a snail shell. And if you kind of take a cross section of one of those rolls, the cochlea, if you completely unwind it, would be like one interconnected kind of tubule system. But this is just showing kind of a cross section of each of those tubes. I like looking at this picture because it just shows a cross section of one of the tubes. And again, your cochlea, the snail shell, this would be as if we would completely unwind that and just take a cross section of the tube and look at the different chambers and what they each contain. So here's the scala vestibule. This is that chamber. It contains the perilymph. The cochlear duct will have the spiral organ, which is the organ of hearing located at the base of it. And the scala tympani also contains perilymph. It is just the chamber located at the base. But this spiral organ within the cochlear duct, this is where we're going to focus on where hearing takes place. This is where you'll have axons that will run to the spiral ganglion. And this ganglion, this cluster of cell bodies, will eventually connect with the cochlear nerve, which will lead any sort of sound impulses to the brain. So here's the cochlea. It describes to you a little bit more about these different chambers. The basilar membrane supports the spiral organ. That's the floor of the cochlear duct. And the basilar membrane is just shown right here. So this supports the cochlear duct and the spiral organ there. The cochlea then, the spiral organ itself contains what we call hair cells. They're functionally arranged in one row of inner hair cells and 3 rows of outer hair cells. And they're sandwiched between the tectorial and the basilar membranes. The cochlear branch of nerve number 8 will run from the spiral organ to the brain. And you can see these here. So here's the basilar membrane, which is the floor of that cochlear duct. And you have outer hair cells and then inner hair cells. And all these hair cells are embedded into this tectorial membrane, which is above it. And again, these hair cells will bend, and that bending will get picked up by fibers of this cochlear nerve. So this is just a transmission microscope look at what the cochlea looks like. It's always nice to see real pictures of this, so you know, like, we're not just making this up. This is actually what it looks like. So I love seeing the real actual pictures of this. So here are what the hairs look like of the inner hair cell, the outer hair cell. They have slightly different functions, but they both do pretty much the same thing. They'll bend in response to the sound waves moving through the cochlear duct, and then the bending will get picked up by the nerve. So this gives you kind of a good, just really simple summary of the internal ear. And this probably simple summary is mainly it might be all you really need to know. You might need to know a couple more details about the cochlea, but for sure about the semicircular canals and the vestibule, this chart is all you need to know about that basic function of that. The properties of sound, I'm going to skip over some of this. The sound travels much slower than light. And the next couple slides take you through sound waves and properties of sound and what the different wavelengths and amplitudes will refer to. So I'm kind of going to skip over just some of the properties of sound in general. The frequency and wavelength of sound. I mean, if you're interested, you can read through this, but I don't include any test questions about this. Pitch and quality of sound. The pitch is the perception of different frequencies, and the quality is the characteristics of different sounds. So this just shows how a high frequency, a short wavelength, will have a higher pitch, and a low frequency, a longer wavelength, will have a lower pitch in sound. Okay, amplitude of sound has to do with the height of those crests, and we measure that in decibels. The threshold of pain is 120 decibels, but I wouldn't want to go much over 90 because severe hearing loss would occur. So this looks at high amplitude versus low amplitude of these crests, these sound waves. And again, high amplitude will equal loud sound, and low amplitude will equal soft. Okay, so this tells us the transmission of sound to the inner ear. The pathway of sound goes through the tympanic membrane. It vibrates the tympanic membrane. That vibration is transferred to these auditory ossicles. And the auditory ossicles, again, the stapes will kind of bang against that oval window. And the vibration transferred to the oval window is amplified about 20 times because the tympanic membrane is about 20 times larger than the oval window. Transmission of sound to the inner ear, the scala vestibule, which was that chamber above, the stapes will rock back and forth on the oval window with each vibration, and this will cause wave motions in this fluid in the scala vestibule. The wave will end at the round window. So the round window, and I'm going to try to, this is a better picture. So here's the oval window vibrating, causing sound waves to travel through the scala vestibule, and they'll travel around kind of the whole length of the cochlea if we were to unwind it. You can see here how the cochlear duct is in between, so the sound waves will travel through that as well. But eventually the sound waves have to go out somewhere, and they're kind of released. Think of that sound wave pressure is released at the round window. So the round window is kind of the end of that sound wave pathway. This kind of just takes you through in general the kind of the steps in how the vibrations are changed into sound waves into the inner ear. So that's kind of a good chart or a good picture diagram to look at to help explain this pathway of sound waves. The physiology of hearing then, the resonance of the basilar membrane. Again, the basilar membrane was the base of the organ of Corti, that spiral organ. The movement of different areas of the membrane will be in response to a particular frequency. The basilar membrane changes along its length. So fibers near the oval window will be short and stiff. So these will be high frequency waves. And fibers near the end or near the cochlear apex will be longer and floppier, and these will resonate with lower frequency waves. You don't really need to know that. It's just kind of interesting. So here, this again explains how we're going to uncoil the cochlea to see how it separates the different frequencies of sound so that we can hear different pitches. Short, stiff fibers will be more at the base, closer to the oval window, and long, floppy fibers will be more towards the apex when we unwind the cochlea. This then takes you through the excitation of those inner hair cells. The stereocilia, the hairs, are just little tiny hairs that are connected to these hair cells. They will bend at their base. The stereocilia project into the potassium-rich endolymph, which with the longest hairs are embedded into this tectorial membrane. So again, this picture shows kind of these stereocilia cells, which are connected to the inner and outer hair cells. They're embedded within this tectorial membrane, and those will be what will bend. So your excitation of inner hair cells, they'll be excited due to channels opening. So remember, whenever we need to send an impulse through or get an action potential, different channels need to open. Specifically, we talked a lot about action potential. I won't have you know all the details of what channels to learn here, but just know that ion channels will open, which will trigger action potentials in neurons of your cochlear nerve. And the bending of those stereocilia hair cells, the bending initially causes them to open. And that is what will cause an action potential to travel through the cochlea. Other than that, you don't really have to know too much more. This takes you through specifically what happens with the bending and what channels are opening. But all I want you to know really simply is that these hair cells will bend, and that's what causes an action potential that's picked up by the cochlear nerve axon. All right, so with that, let me just take a quick look. I'm not going to have you learn any more pathway to the brain from there. This takes you through a little bit of the vestibular apparatus with the receptors in the semicircular canals in the vestibule. So this will take you through equilibrium, orientation. We're focusing now on the vestibule and the semicircular canals. The maculae are sensory receptor organs that monitor static equilibrium. They will respond to linear acceleration forces. So again, we're focusing here on equilibrium in the semicircular canals and vestibule, excuse me. But I'm not going to have you know too much more than that or of the macula. So I'm going to skip over that for now. Oh, really forever. We're not going to go back. We just can't cover everything. And there's certain things that I want you to know. This tells you how the tipping of your head will move these hair cells. And again, the movement of those hair cells from that tipping of the head force, that movement is picked up by the nerve axons. Okay, and I think that's what I wanted to get through. I think, was there one more thing here? This takes us through motion sickness. Yes, I think I wanted to end a little bit here talking about motion sickness, and then we'll move on to part E. So motion sickness, so this whole equilibrium problem when you're going on a ride in one of those county fair rides or in a car, these equilibrium problems are usually unpleasant. They can cause nausea, dizziness, sense of balance. Motion sickness itself is when your sensory inputs are mismatched. So the visual input differs from the equilibrium input. So what you're seeing doesn't match up with what your ear balance and equilibrium is picking up. That conflicting information will cause motion sickness. The warning signs, I'm sure we've always all felt some of that. You can take some anti-motion drugs, but again, that's because what you're seeing doesn't match up with what your ears are trying to counteract for. Deafness can be conduction deafness, where there's blocked sound conduction to fluids of the internal ear. The causes could be earwax, perforated eardrum, otitis media, so an inflammation of the middle ear, or osteosclerosis of the ossicles, so your ossicles basically being wearing down. Or we could have sensory neural deafness, which is damage to neural structures at any point from the cochlear hair cells to the auditory cortical cells. And this is just typically from gradual hair cell loss from loud noises, most likely. All right. Tinnitus is ringing, buzzing, or clicking sounds in the absence of the auditory stimuli. This could also be due to inflammation of your middle or internal ear. Sometimes they say as a side effect of aspirin as well. I don't know, I've never experienced that, but all right. Meniere's syndrome, causes of this are vertigo, nausea, and vomiting. This will affect your cochlea and semicircular canals themselves. Okay, questions on any of that before we kind of move on to part D here? E, excuse me, we're skipping part D. All right. So part D has basically, simply, we're going to kind of cover reflexes in part D. We're going to review the neuromuscular junction. So part E talks about motor endings, motor activity. So in your peripheral nervous system, the motor endings will mostly activate all skeletal muscle, visceral muscle. So your internal organs that are usually smooth muscle and glands. The innervation of skeletal muscle takes place at your neuromuscular junction, and the neurotransmitter acetylcholine will be released when the nerve impulse reaches the axon terminal. Some of this might be a review, but I'm going to go over it one more time because there is a test question labeling a picture like this. So I just want to review this one more time. So acetylcholine will diffuse across the synaptic cleft. It'll attach to acetylcholine receptors. So again, we're talking about how a nerve will innervate a muscle, and acetylcholine will always be the neurotransmitter that is released. So acetylcholine will bind to the receptors, and this will result in the movement of sodium and potassium across the membrane. By now, you should know that whenever sodium or potassium crosses a membrane, we get a depolarization. So we're going to get some sort of action potential, which will spread to adjacent areas, which will trigger more opening of sodium voltage gated channels. This will lead to a muscle contraction. So we're basically, if we look here, again, a picture like this, especially kind of focused on this area, the neuromuscular junction, there's a picture labeling some of the structures in this. So we get to kind of our motor neuron, the axon of the motor neuron. As the action potential travels to the end of that, it'll open up calcium channels. And when calcium enters, that causes your synaptic vesicles to release the acetylcholine inside of them. And that acetylcholine is the neurotransmitter, which when it binds to the acetylcholine receptors, will cause sodium usually or potassium to diffuse into the cell and potassium out of the cell. And that will cause a graded potential, which will eventually lead to an action potential. And an action potential, again, is just the traveling of an electrical impulse through either an axon or, in this case, the muscle fiber. Okay. The autonomic motor endings and visceral effectors are simpler than somatic junctions. The branches for what we call synapses and passant, or in passing with effector cells via varicosities. Acetylcholine and norepinephrine connect indirectly via second messengers. So this is when we're talking about anything that's under the subconscious level, so your autonomic motor nerve endings and your visceral effectors. So this is just a look at how a varicosity, this will release its neurotransmitters into a wider synaptic cleft. So we call that a diffuse junction. And I think from here, I want to move on to the reflexes. So reflex activity, there's a couple basic questions about reflexes. Reflexes are important because reflexes are things that your body and nervous system do without using the central nervous system. Well, they'll use your spinal cord, but they won't travel up to your brain at all. An inborn intrinsic reflex is a rapid, involuntary, predictable motor response to a stimulus. And an example of this are your muscles maintaining posture or any other control of visceral activities in your organs. It can be modified by learning and conscious effort, whereas a learned reflex is a result from practice or repetition, like your driving skills. Think of a reflex like cutting or touching the brake pedal like directly. That's a learned reflex that you've trained your body to slam on the brakes when something bad happens. These are the components of a reflex arc or a neural path. And you should know these components. And I think there's eventually a picture, and I think there's a similar picture to this on your exam as well. So knowing these components of a reflex arc, the receptor is the site of the stimulus action. The sensory neuron transmits sensory afferent impulses to your central nervous system, which is just your spinal cord. The integration center will either be monosynaptic, meaning there's only one synapse, or polysynaptic, several synapses. And then the motor neuron will conduct an efferent impulse from the integration center to the effector organ. And the effector will be a muscle fiber or gland cell that responds to the efferent impulses by contracting or secreting. So we can have somatic reflexes, which will activate your skeletal muscle, or autonomic reflexes will activate all your viscera or visceral effectors, smooth or cardiac muscle, or your glands. So here's a look. Let's say there's a painful stimulus. Let's say you prick your finger with that looks like a nail, but even like a sliver, that sensory sends a sensory information stimulus through your sensory neuron. It will synapse with an interneuron in the integration center at that level of the spinal cord, and that will send out an immediate motor response to the skeletal muscle. So you'll immediately usually pull your hand away from sort of painful stimuli. Spinal reflexes occur without direct involvement of higher brain centers. The brain will still be advised of the spinal reflex activity, and it may have an additional effect on the reflex, but the spinal reflex itself will occur just with that level of the spinal cord. We can test these somatic reflexes, and that's important in a clinical setting. This is why your doctor bangs a rubber hammer against the patellar tendon to test that stretch reflex. And if when testing these reflexes, if the reflex is exaggerated, so let's say your doctor bangs on your patellar tendon right below your knee and your leg kicks him in the face or something, that would be an exaggerated reflex, something still probably not right. Distorted, weak, or absent, that will indicate degeneration or pathology of a specific nervous system region. So it's a really important clinical tool that doctors, nurses use. The most commonly assessed reflex are stretch, flexor, and superficial reflexes. To smoothly coordinate skeletal muscle, the nervous system must receive proprioceptor input. So again, proprioceptors are all of the input that the body kind of brings in understanding the relation of tendons and joints to one another. So regarding the length of the muscle, this is information sent from muscle spindles or the amount of tension in the muscle, and this is sent from tendon organs. A little bit about muscle spindles. These are skeletal muscle fibers that are enclosed in a connective tissue capsule, and the end regions will contain actin and myosin that can contract, and they're these regular effector fibers of muscle referred to as extrafusal muscle fibers. So muscle spindles basically have sensory endings that they have nerve endings that will wrap around these muscle spindles to help, they'll be stimulated by any sort of stretch in the muscle. The flower spray endings, it's another type of nerve ending. They're small axons at the spindle ends, and they're stimulated by a degree of stretch only. Just really simply put, these muscle spindles, they just are, they include nerve endings which surround muscle fibers, and they can be, a stimulus can go through the muscle spindles, and that is what is picked up by some of these reflex arcs. More functional anatomy of muscle spindles. I'm not going to go into too much more of that because you don't need to know much more about muscle spindles, but it'll show or be able to pick up if a muscle is being stretched. Okay, the stretch reflex, the stretch will activate the muscle spindle. So the stretch reflex is when, when your doctor hammers against your patellar tendon, that tendon is attached to a muscle. So this will activate the muscle spindles in the muscle. Reciprocal inhibition will also occur. So these are afferent fibers that synapse with interneurons that will inhibit specific motor neurons of antagonistic muscles. So for example, in your patellar reflex, it'll cause the quadriceps to stretch or extend as if you're kicking out or kicking a soccer ball, but it'll also inhibit the hamstrings. So your hamstrings will relax to allow for complete just stretching out of your hamstrings, of your quadriceps, and your hamstrings will relax. All stretch reflexes are monosynaptic and ipsilateral. What this means is there's only one synapse involved, so one kind of connection point between neurons. And ipsilateral means that the motor activity is on the same side of the body. Sometimes, as we learned, that the sensory input will go to the left side of the brain, and the left side of the brain will control a motor response to the right side of the body. And that's called contralateral. But ipsilateral means this happens on the same side. Positive reflex reactions provide two pieces of information, which is important clinically. It proves that your sensory and motor connections between the muscle and the spinal cord are intact. So if any sort of reflex is lacking, there would probably be some sort of disconnect between your sensory and motor connection. And the strength of the response indicates the degree of spinal cord excitability. These stretch reflexes can be hyperactive or absent, like we talked about, if there's any sort of nerve damage or ventral horn injury, because the motor response comes out of the ventral or anterior horn of that gray matter. Reflexes are usually absent in people with chronic diabetes or neurosyphilis and during a coma. So again, a simple test of the patellar reflex can tell the doctors a lot about the nervous system. Okay, so this is a look at the stretch reflex and how it's taken up. So we have the muscle stretch is initiated by a stimulus, and usually it's initiated by the muscle spindle being stretched. When the patellar tendon stretches out that muscle, that sends out the sensory neuron, sends that sensory information to that level of the spinal cord. There might be an interneuron, which could have an inhibitory effect on the antagonistic muscle, like the hamstring muscle we said, or it would have a positive impact on the quadricep muscle, and that would cause your leg to kick out. So that's the stretch reflex. Ipsilateral, meaning it happens on the same side of the body that the reflex occurs in. So here shows the patellar, the knee jerk reflex. It's an example of that stretch reflex. It occurs in spinal cord segments L2 to L4. So again, it's just amazing how far medicine has come. So if your stretch reflex is absent or hyperactive, there's a problem with this area of the spinal cord. So this takes you through those steps of that stretch reflex. And let me just see here. So that stretch reflex and the basic reflex arc you should understand, and the basic anatomy of a reflex arc. We're going to talk a little bit about the flexor, the withdrawal reflex, and the crossed-extensor reflex. These are two other types of reflexes. The flexor or withdrawal reflex is initiated by a painful stimulus, and it causes automatic withdrawal of a threatened body part, which is what I kind of described before when we were talking about the basic kind of function or structure of a reflex arc. It's always ipsilateral and polysynaptic, so it always happens on the same side. Many different muscles may be called into play, so it needs to be polysynaptic, meaning you need to have many different synapses involved between neurons, because you're going to have several neurons going to possibly several different muscles to withdraw a part of your body that's under painful control. The brain can override this. So for example, if you know your finger is going to be pricked for a blood test, your brain can override pulling of that arm away, which is kind of interesting. So your brain does have the ability to override it in certain situations. Then the crossed-extensor reflex occurs with the flexor reflexes in the weight-bearing limbs to maintain balance. And your crossed-extensor reflex is important. It consists of an ipsilateral withdrawal reflex and a contralateral extensor reflex. That sounds like Greek. So what does that mean? So an example of this would be stepping barefoot onto broken glass. That would cause a withdrawal reflex on the same side. So let's say your left leg steps on a piece of glass. That'll be an ipsilateral withdrawal reflex response. Your left leg will try to lift itself off of that broken glass immediately. But what also happens at the same time is what we call the crossed-extensor reflex. Your opposite leg will extend to help support the weight shift. So even just try this. You can stand up, pretend you step on a piece of broken glass with your left foot. You'll notice in order to counteract the change in balance, your right leg will have to automatically extend itself to support the weight shift. Another example of this is someone grabbing your arm. It causes that arm to flex and the opposite arm to extend to pull the body away. So this seems like really simple talk, all of your reflexes, the stretch reflex, knee jerk reflex. But again, it's just fascinating that this is happening without your brain being involved. It happens automatically. Your body knows what to do basically to avoid getting hurt. So I wanted to go over those three reflexes: the stretch reflex, the flexor, and the crossed-extensor reflex. So this just shows, for example, stepping on a piece of broken glass, the flexor reflex will pull away that ipsilateral leg. So you'll pull away off the piece of glass. But on the contralateral leg, the contralateral sign, and you can see how the interneurons are causing they're inhibiting, they're exciting specific muscles to pull your leg off of the glass. And it's also doing the same thing on the opposite side. It's causing this person's left leg to extend to support the body weight when it needs to step off of that glass. Superficial reflexes, this is a superficial like touch reflexes and the cutaneous stimulation of an area. the abdominal reflex, the plantar reflex. I think I'm going to kind of skip over these. It's really fascinating, but I don't include any test questions on it. And I think we've kind of covered a lot from this chapter probably. We'll talk a little bit about the Babinskis, and then I think we're pretty much done. Yeah. So the Babinski sign, if a primary motor cortex or a corticospinal tract is damaged, and that's one of the tracts in a motor output response, the plantar reflex is replaced by an abnormal reflex, and we call that the Babinski sign. The great toe will actually dorsiflex, and the smaller toes will fan laterally. So dorsiflexion means your toes kind of flex up towards your nose, and your smaller toes would kind of fan out or separate. Infants will exhibit this Babinski sign until they're about a year old. So it's normal for infants less than 1 year of age to dorsiflex. In order to test this, you would take a pencil and kind of do like a circular kind of like structure or the back of a pen on an infant's foot, and you can try it on your foot too. So an infant like my baby, I should pull him up here and we could show this to you. His toes would flare out and he would point his toes up. But in adults, we would always, our toes would curl over because our nerves have been completely myelinated. So you can kind of test that on any babies if you want to later. So I'll stop the recording there.